I'm Roberta Ferrucci. I'm a researcher from University of Milan, Italy. Today, I talk about non-invasive transcranial stimulation. In particular, I talk about cerebellar transcranial direct current stimulation. First of all, what is cerebellar TDCS? Cerebellar transcranial direct current stimulation is a non-invasive technique for inducing prolonged functional change in the human cerebellum. Available data show that this simple and safe technique can modulate several motor and motor cerebellar functions in healthy humans. The technique consists in delivering for minutes through a surface scalp electrode a weak direct current over the cerebellum by about 1–2 milliampere. The technique is painless and the stimulation can be delivered during any motor or cognitive activity. Research findings already provide evidence that the cerebellar TDCS can induce neurophysiological change in the cerebellar-brain interaction and can influence gait adaptation, motor learning, and cognition in healthy humans. Preliminary clinical observations suggest that the change induced by cerebellar TDCS could be clinically useful in patients with various disorders involving cerebellar dysfunction. And we aimed to estimate the electric field and current density distributions during cerebellar TDCS using a computational technique that were applied in 3 human realistic models of different age and gender. We found that the stronger electric field and the current density occurred mainly in the cerebellar cortex, with some spread up to 4% toward the occipital cortex. Despite inter-individual differences, our modeling study confirmed that the cerebellum is the structure mainly involved by cerebellar TDCS. Evidence from clinical studies suggests that the cerebellum may be involved in pathophysiology of movement disorders such as dystonia, essential tremor, Parkinson's disease, cerebellar ataxia, and may be a useful target for TDCS intervention. Parkinson's disease, to evaluate how cerebellar TDCS affect levodopa-induced dyskinesia and the cognitive function in Parkinson's disease, we delivered bilateral nodal and sham TDCS. After patients received a nodal cerebellar TDCS and motor TDCS for 5 days, the UPDRS score dyskinesia section improved. Conversely, the other variables were unchanged. Despite the small sample size, these preliminary results show that a nodal TDCS applied for 5 consecutive days over the motor cortical area and over the cerebellum improved the levodopa-induced dyskinesia in patients with Parkinson's disease. This finding provides the first evidence that cerebellar TDCS affect levodopa-induced dyskinesia, thus corroborating and extending our knowledge on the role of the cerebellum in pathophysiology of Parkinson's disease. About dystonia, to investigate the role of the cerebellum in dystonia, Bradman and colleagues evaluate whether cerebellar TDCS improve and writing and cyclic driving kinematics by reduced CBE evoked by TMS in patients with writing dystonia. And the results show that cerebellar anodal TDCS reduce and writing mean stroke frequency and average pen pressure, and increase speed and reduce pen pressure during fast cycling drawing. Primary dystonia is characterized neurophysiologically by reduced inhibitory mechanism and abnormal regulation of plastic responses. The method commonly used to induce long-term potentiation plasticity is paired associative stimulation. This protocol induced plastic change in excitability in the human motor cortex. In their study, Sadrik and colleagues used the cerebellar TDCS to examine the electrophysiological parameters such as resting and active motor threshold, motor cortex excitability, recruitment curve, and the cortical silent period in 10 patients with writing dystonia. Patient completed a 2-session study with the sham and with a nodal, in which the cerebellum was stimulated along with the simultaneous application of paid associative stimulation. Patients were also clinically evaluated with the writing movement subscore Brighter's cramp rating scale and with the self-reported visual analog scale. The results were negative and do not provide evidence that a nodal cerebellar is beneficial for after a single session. Based on these limited and contradictory results, we conclude that the evidence supporting cerebellar TDCS as a clinical viable methods for treating dystonia is unconvincing. To the best of our knowledge, no one has investigated the effect of consecutive cerebellar TDCS session or the effect of combining it with motor training. And further research is needed to investigate ways for increasing the magnitude of the cerebellar TDCS effect. About essential tremor, we have a few studies, and we think that the results do not provide evidence that cerebellar TDCS is beneficial for the essential tremor. And we think that further research is needed to investigate ways for increase the effect of cerebellar TDCS. I think that the most important disease studied with the transcranial direct current stimulation is cerebellar ataxia, and a recent study has investigated the role of TDCS to modulate the activity of cerebellum in ataxic disorder, and has reported interesting results. To evaluate the effect of a nodal TDCS of the cerebellum, Grimaldi and colleague conducted a study with 9 ataxic patients. The authors studied the stretch reflexes in the upper limb and examined upper limb dexterity and the coordination using a mechanical counter test. These researchers also used a computerized postograph during the 3 experimental paradigm. And their results show that a nodal TDCS 1 mA for 20 minutes over the right cerebellar hemisphere reduced the amplitude of the long latency response, but did not affect the short latency response or MCT score compared to baseline and sham group. Furthermore, the positive parameters remained unchanged following sham or active stimulation of a region in front of the vermis. These data collectively demonstrate that a nodal TDCS applied over the cerebellum reinforces the inhibitory activity exerted by cerebellar cortex over cerebellar nuclei. TDCS of the cerebellum appears to be a novel method to study the modulation of long latency by the cerebellar cortex. In a subsequent study, the same authors performed a TDCS over the cerebellum for 5 minutes, immediately followed by TDCS applied over the contralateral motor cortex to assess upper limb tremor and dysmetria in 2 patients with dominant spinocerebellar ataxia. They found that for a postular tremor, this protocol induced a reduction in the amplitude of the oscillation and the level of the index in both patients as reported by quadratic power spectral density. And also, this protocol had a positive effect on action tremors as observed by the drop in the magnitude of low frequency oscillation. Remarkably, following the TCCDCS, hypermetry occurred along with a reduction of the onset latency of the antagonist EMG activity in both patients. Despite the small sample size and the lack of follow-up, precluding the investigator from assessing how long the effect lasted, these results are highly encouraging. The combination TDCS of the cerebellum with TDCS of the motor premotor cortex demonstrated that this technique may be considered as a symptomatic therapeutic strategy for upper limb deficit in disability in disabling cerebellar ataxia, representing a novel approach in the field of cerebellar neuromodulation. An interesting therapeutic effect was also observed by the Ferrucci and colleague. In a double-blind randomized sham-controlled study, they investigate whether a single session of cerebellar nodal direct current stimulation could improve symptoms in 9 patients with ataxia. Each patient received both a nodal and sham cerebellar for 20 minutes, 2 mA in 2 different sessions, separated by at least 1 week. After cerebellar TDCS, there was a significant improvement in the functional clinical score as observed with the scale for the assessment of rating ataxia, the International Cooperative Ataxia Rating Scale, and in motor task measurement with the 9-hole peg test and 8-meter walking time, assessment with the entire cohort of patients. Specifically, the individual assessment of the force score with the HECARS scale revealed a significant improvement in the posture, gait, and the limb coordination score. Moreover, single group analysis in the spinocerebellar ataxia and the cerebellar variant of multi-system atrophy course demonstrate a significant effect from a nodal cerebellar TDCS. Only in the spinocerebellar ataxia group where there are significant difference in also in the 8-meter walking testing, but not in the other variable. Not in the other variable. The investigators concluded that a single stimulation session applied to the cerebellar cortex can temporarily improve symptoms in patients with ataxia and may have therapeutic potential in these patients, but more powerful stimulation may be needed. This preliminary study showed that cerebellar TDCS is safe and can improve neurological symptoms, especially in patients with ataxia. While this finding is promising, the clinical efficacy of this technique in patients with neurological disorder remain to be established by large controlled clinical study. And obviously, future research efforts should be directed to identify the optimal stimulation parameter, electromontage, sites, duration, intensity, number of sessions, and potentially targeting specific type of neurological disorder on individual patients. In recent years, a growing body of literature has investigated the use of non-invasive brain stimulation technique as putative treatment also in Huntington disease. And our aim was to evaluate the effect of cerebellar transcranial direct current stimulation, the motor outcome in patients affected by Huntington disease, encompassing at the same time the current knowledge about the effect on non-invasive brain stimulation, both on motor and non-motor dysfunction in this patient. 4 patients, 2 females, were enrolled and underwent cerebellar TDCS, both a nodal or sham, elapsed by at least 3 months for 20 minutes at 2 mA for 5 days in a week. Clinical score were assessed by using the Unified Huntington Disease Rating Scale and immediately before cerebellar TDCS and at the end of the 5-day treatment and after 4 weekly at the end with the TDCS. We found that a nodal cerebellar TDCS improved the motor score compared to baseline, whereas sham stimulation left them unchanged. In particular, following a nodal cerebellar TDCS, the motor score significantly improved, especially regarding the subitem dystonia. both at the T1 and T2 compared to sham stimulation. And we conclude that the cerebellar TDCS improved the motor score in Huntington disease with effect lasting for about 4 weeks after TDCS completion. This is the first study discussing the putative role of cerebellar non-invasive stimulation for the treatment of Huntington disease. In conclusion, cerebellar TDCS is a novel, safe, and effective neurostimulation technique for non-invasive modulation of cerebellar excitability. This preliminary study showed that cerebellar TDCS is safe and can improve neurological symptoms, especially in patients with ataxia. While this finding is promising, the clinical efficacy of this technique in patients with neurological disorder remain to be definitively established by large controlled clinical studies. Future research efforts should be directed toward identifying the optimal stimulation parameters and potentially targeting specific type of neurological disorder or individual patients. And thank you for your attention.